organizational experience. Oh, we're recording now. Yay. Our positions and priorities are informed by our organizational experience and core agency values, which are aligned with the recovery model and the goals of the mental health consumer movement. This webinar reflects Cal Voice's perspectives on pending legislative efforts to modernize the MHSA. Your views and concerns may differ. You might represent different constituencies. You might see things from a different perspective. All of that is welcome. So I just want to emphasize the fact that this is from our perspective. This webinar is about SB 326, the Behavioral Health Services Act. The legislature did not release the full text of SB 326 until June 19th. It substantively amends, repeals, and or adds 59 different statutes, including the entire MHSA. So Cal Voices has not yet fully analyzed all of the bill's proposed changes to the MHSA or the extent of its impacts on clients and peers. This webinar is narrowly focused on how SB 326 alters the MHSA's current program and expenditure components. It does not explore all the ways that SB 326 will change the MHSA, and that can be explored in future webinar sessions. The information used to develop this webinar is rapidly evolving and might change at any time. New critiques and analyses of SB 326 are being published every day. Further legislative amendments are also likely. Future webinars in this series will address bill updates and new understandings, our own and others, as they emerge. And then good to know. So if you want the original sources of any factual information provided in this webinar, if you want to know, hey, where did you get that information from? Obviously, our opinions came from our heads, right? But any of the facts, you can email Claire. Her email is here in this slide, and you can type SB 326 webinar in the subject line, and then just identify the slide number and what information that you want the source of. And we will be disseminating the slide deck after the training, or the webinar, I should say, sorry. So really quickly, are there any questions before we begin? We can take about 2 minutes and jump into any questions folks may have right now. All right. That looks like no. Karen Klatz still has their hand up, so I'm not sure if you mean to have your hand up or not, but it's been up for a while. All right, I'm going to guess that nobody has any questions.
Yeah, I don't mean to have it up. I don't know what happened. Sorry about it.
Okay, that's okay.
Thank you.
That's all right. All right, I don't see any other hands. So we'll go ahead and get going. So again, session 1 agenda, MHSA program and expenditure requirements, origins of current efforts to modernize the MHSA, SB 326 program and expenditure requirements, next steps and action items. All right, so we're going to jump into part 1, the MHSA program and expenditure requirements. So before we jump into that, I want to give a little bit of history and background because I don't know how familiar with the MHSA all of the participants are on this webinar today. So MHSA was passed by Proposition 63, which was a grassroots ballot initiative to establish the Mental Health Services Act, passed by California voters in November of 2024. It was written by Darrell Steinberg, who was then a California Assembly member, and Rusty Seelix, who was then Executive Director of Mental Health America of California, with significant input from mental health consumers, family members, peers, providers, and other key stakeholders. It created a 1% tax on personal incomes over $1 million to expand mental health services, including services that are not reimbursable under Medi-Cal, and transform California's public mental health system. So one of the key aspects of the MHSA was system transformation. So here's a little bit of history about what that system transformation was intended to entail. The first and foremost thing that everyone needs to recognize is that the MHSA is not increased funding for the old mental health system that we've known for the past decades. Instead, is a complete transformation to a new system. Now we have a fail-first system of waiting for people to hit rock bottom. Hospitalizations, incarcerations, out-of-home placements, special education, and other failures are the norm before getting the services needed. Now we must move from fail first to help first. Give everyone the right care at the right time in the right place. This was from a preliminary implementation guide drafted by Daryl Steinberg and Rusty Steelix in 2005 when the MHSA first passed. Funding provided through the MHSA will be used to transform the current mental health system from one that focuses primarily on clinical services into one in which county mental health programs can enter into partnerships with clients, their families, and their communities to provide under client and family direction, whatever it takes to enable people to attain their goals. This was written by California's Department of Mental Health during MHSA implementation in 2005. Although counties are usually encouraged to maximize other funding sources wherever possible, for counties to be truly innovative and change or transform their programs and mental health services, funds requested under the MHSA should not be driven by the goal of maximizing Medi-Cal reimbursement. A transformed mental health system will require new and different activities and services not currently funded through Medi-Cal and other public or private payers, and will include individuals not currently eligible for Medi-Cal funding. So again, this was part of MHSA implementation that was written by California's Department of Mental Health in 2005. So some of the transformative aspects of the MHSA included expansion of successful pilot programs that were established under AB 34 and AB 2034. Both were authored by Daryl Steinberg for individuals at high risk of incarceration, hospitalization, and homelessness. The MHSA established full service partnerships, or FSPs, offering whatever it takes to high-risk adults and children, including intensive mental health services, and also non-mental health services that address their basic needs. It created new programs and services focused on prevention, early intervention, wellness, resilience, and recovery to move beyond existing fail-first approaches towards help-first approaches. It requires ongoing partnership with constituents and stakeholders that includes meaningful stakeholder involvement on mental health policy, program planning and implementation, monitoring, quality improvement, evaluation, and budget allocations. And it provides funding for capital facilities, technology, and workforce education and training needs to complement new programs and services. The MHSA also introduced specific general standards that counties must adopt when they're planning, implementing, and evaluating the programs and or services funded by the MHSA. So these are sort of like core values of the MHSA that need to be reflected in all programs and services. Community collaboration, cultural competence, client-driven services for adults, family-driven services for children and youth, wellness, recovery, and resilience-focused services and programs, and also integrated services experiences for clients and their families. So MHSA funding overview. So as I mentioned, it created a 1% tax on personal incomes over $1 million. Tax revenues are collected by the state and held in the state's mental health services fund. Revenues held in that fund are then allocated partially to the state and then also to individual counties to pay for the administration, oversight, and implementation of MHSA programs. MHSA funding is restricted, meaning that it can only be used to pay for specific program services and expenditures that are identified or allowed under the Act. So some of those funding restrictions include no funding for standalone substance use disorder services. MHSA funds must be used for mental health services to expand existing services and cannot be used for SUD treatment unless the individual has a co-occurring disorder. Non-supplantation is also an important aspect. Funding for mental health services must be maintained at pre-MHSA levels adjusted for inflation. So MHSA funds cannot be used to backfill other revenue cuts or shortfalls. No unfunded mandates or liabilities. So the state cannot change how mental health services are financed to create greater costs or financial risks for counties unless counties are compensated for those costs or risks. No commingling of funds. So MHSA revenues have to be held in a separate mental health services fund apart from other state and local mental health funds. And earned interest on that fund must be reinvested in the fund. No loans. So MHSA revenues cannot be loaned to any other state or local fund. And then authorized in programs and expenditures only. So MHSA funds may only be used to pay for programs and expenditures that are authorized under the Act. Additionally, MHSA funding can only be used to pay for the programs and expenditures listed in counties MHSA 3-year plans and annual updates, right? So all of the expenditures and the programs that MHSA funds are used to pay for have to be in county's 3-year plans or annual updates. And all expenditures have to be consistent with county's currently approved plans or updates. And funding cannot be used for incarceration or law enforcement purposes. So it cannot be used to provide services for people who are incarcerated, except to facilitate discharge. It cannot be used for any law enforcement function or for any function that supports a law enforcement purpose. So MHSA revenue allocations. So as I mentioned, there's a 1% tax on personal incomes over $1 million. It's collected by the state franchise tax board, and then it's held in the state's mental health services fund. Out of all of that money, 5% goes to the state for administrative purposes, and 95% of the funding goes to the counties. So state agencies get 5% of MHSA revenue. It pays for things like administrative costs of implementing and overseeing the MHSA. Some of the agencies that receive this funding are Department of Healthcare Services, the Behavioral Health Planning Council, the Office of Healthcare Access and Information, it used to be known as OSHPD, the Mental Health Services Oversight and Accountability Commission, the California Department of Public Health, and other state agencies involved with implementing and overseeing any aspects of the MHSA. Administrative costs include funds to assist consumers and family members to ensure the appropriate state and county agencies give full consideration to concerns about quality, structure of service delivery, or access to services, and also amounts sufficient to ensure adequate research and evaluation regarding the effectiveness of services being provided and the achievement of outcome measures set forth in the MHSA. Counties get 95% of all MHSA revenues collected by the state. They go to counties to pay for the cost of implementing and overseeing mandated programs, services, and activities under the MHSA. Counties must develop 3-year program and expenditure plans and annual updates that include the following components: prevention and early intervention programs, or PEI programs, innovative programs, community services and supports, which include full service partnerships, and general system development, project-based housing and outreach and engagement. Other expenditures that come out of the CSS bucket include capital facilities and technology, workforce education and training expenses, and also funding for to maintain a prudent reserve. And then also costs of annual planning or the community program planning process are also deducted from community services and supports. So to give a very broad overview of what those funding allocations currently look like at the county level, 19% goes to prevention and early intervention, 5% to innovative programs, and then 76% to community services and supports, from which other types of expenditures are also deducted. Okay, so we talked about that, the different funding buckets. So one thing to note is that 51% currently of PEI program funding must be used to serve individuals aged 25 and younger. Let's see, out of the other expenditures and community services and supports and other expenditures, the majority, or approximately 51% of CSS funds must be used on FSP programs. Up to 20% of the 5-year average of CSS funds may be spent on capital facilities and technology, workforce education and training, and prudent reserve combined. And the total prudent reserve balance cannot exceed 33% of the 5-year average of community services and supports funding. I know I'm going through this quickly, but I don't know how much of this is review for some folks, and it's also sort of foundational to the changes in SB 326. Up to 5% of the annual county MHSA revenues of the total revenues may be spent on annual planning costs, including the community program planning process. And the rest of CSS funding goes to general system development, project-based housing, and outreach and engagement programs. So to break that down, that's sort of what it looks like. When we're looking at these different funding components, the darker shade, so for instance, the darker blue is, has mandatory restrictions on it. So PEI funding for individuals under age 25 is 51%, so it's darker. The majority of CSS funding has to go to FSP, so it's darker. And then the lighter red has a little bit more flexibility. The amounts that are allocated to these different programs and services are flexible. So again, PEI programs. So these are programs and services to prevent mental illnesses from becoming severe and disabling. Programs and services under PEI include outreach to families, employers, primary care providers, and others to recognize the early signs of mental illness, access and linkage to treatment for children, adults, and seniors with SMI or severe mental illness as early in the onset of these conditions as practicable, stigma and discrimination reduction activities, and strategies to reduce negative outcomes from untreated mental illness, including suicide, incarceration, school failure and dropout, unemployment, prolonged suffering, homelessness, removal of children from their homes. The innovations component is 5% of county's total MHSA funding. Innovative projects can be designed for any of the following purposes: to increase access to underserved groups, increase quality of services and produce better outcomes, promote interagency collaboration, increase access to services, including permanent supportive housing, and also to fund innovative approaches that introduce new mental health practices or approaches, including prevention and early intervention approaches, change or adapt existing practices and approaches for a new setting or community, introduce new or promising community-driven practices and approaches that have been successful in other non-mental health contexts, and also to provide permanent supportive housing. And then we have CSS, or community services and supports, and other expenditures, which is 76% of the county's total MHSA revenues. CSS service categories include full service partnerships. A majority of CSS funding must be used for these programs. It also includes general system development, which a component of that is MHSA project-based housing. We'll explore more of that in session 2 of this webinar series. It also includes outreach and engagement activities. And then, as I mentioned before, other MHSA expenditures that are also funded from the CSS bucket include capital facilities and technology, WET, our workforce education and training, prudent reserve allocations, and then annual planning costs for the community program planning process. So there was a question in the chat about what are FSPs, what do those programs do? And here we have the answer. So the CSS funds full service partnerships that serve individuals with severe mental illness or severe emotional disturbance if they're children who meet medical necessity criteria and other eligibility requirements to receive mental health services in the public behavioral health system. And the people also have to be, to qualify for FSPs, they have to be currently unserved or underserved, and they have to be either homeless or at risk of becoming homeless, or involved or at risk of becoming involved in the criminal justice system, or at risk of involuntary hospitalization or institutionalization, as evidenced by frequent use of hospitals or ERs as a primary source of mental health treatment. So under community services and supports is also general system development. These programs and services provide mental health treatment, including alternative and culturally specific treatments, peer support, supportive services to assist clients and families in obtaining employment, housing, and education, wellness centers, personal service coordination and case management to assist clients and families in accessing needed services, needs assessment, individual services and supports plan development, crisis intervention and stabilization programs, family education services, and project-based housing. These programs and services also can be used to improve the county mental health service delivery system for all clients and their families. So activities might include system level advocacy, and also to develop and implement strategies for reducing ethnic and racial disparities in access to mental health services and treatment outcomes. So counties can use a general system development funds under CSS for the costs associated with project-based housing. And that includes purchasing and renovating or constructing housing, master leasing of project-based housing, repairing damages to housing when a tenant, in which a tenant resides or resided. And also they can establish project-based housing funds with local government housing entities and partner with those entities to provide housing. Counties cannot use general system development funds for client-based housing expenditures, including housing vouchers, rental subsidies, utility startup deposits, utility costs, and furniture rental. So it's basically the cost of actual facilities and construction, and not for providing, you know, rental assistance and things like that. So outreach and engagement under the CSS category includes programs and services that provide strategies to reduce ethnic and racial disparities, food, clothing, and shelter when the purpose is to engage unserved individuals and their families in the mental health system, outreach to CBOs or community-based organizations, schools, tribal communities, primary care providers, and faith-based organizations, and outreach to individuals, including community leaders, unhoused people, and people incarcerated in county facilities. We've talked about this before. Allocations for capital facilities, technology, workforce education and training, and prudent reserves come out of the CSS funding bucket, so I won't go into this in more detail. And then also funding for annual planning or the community program planning process comes out of the CSS funding category. And up to 5%, counties can use up to 5% of their total annual MHSA revenues for these expenditures. So counties have to develop their 3-year program and expenditure plans or 3-year plans, demonstrating how they'll spend their MHSA funds, and they have to update these plans annually. Those are called annual updates. County MHSA funding allocations must include funding for annual planning costs. The totals of the costs shall not exceed 5%. And then planning costs shall include funds for county mental health programs to pay for the cost of consumers, family members, and other stakeholders to participate in the planning process. So each 3-year plan and annual update shall be developed with local stakeholders, including adults and seniors with severe mental illness, families of children, adults and seniors with severe mental illness, providers of services, law enforcement agencies, education, social services agencies, veterans, representatives from veterans organizations, providers of alcohol and drug services, healthcare organizations, and other important interests. Counties shall demonstrate a partnership with constituents and stakeholders throughout the process that includes meaningful stakeholder involvement on mental health policy, program planning and implementation, monitoring, quality improvement, evaluation, and budget allocations. So the whole idea here is that annual planning for MHSA expenditures need to involve community members and people who are receiving services. The community program planning process under the MHSA is used to develop 3-year plans and annual updates. Counties under the MHSA regulations are required to ensure that stakeholders have the opportunity to participate in the process, including representatives of unserved and or underserved populations, stakeholders that reflect the diversity of the demographics of the county, and clients with serious mental illness, serious emotional disturbance, and their family members. And counties are required to provide training for stakeholders, clients, and families who are participating in the process so that they can provide meaningful feedback and involvement. So this is sort of a quick breakdown or a general overview of MHSA funding as it currently exists and how funding is allocated. So under this chart, you can see that, let's say there's $1 billion that the state receives for MHSA tax revenues. 5% goes to the counties, 5% goes to the state, 95% goes to the counties. And so out of county MHSA programs and expenditures, 19% or $180.5 million needs to be allocated to PEI. 47.5 million needs to be allocated to innovation programs, and then 722 million to CSS and other expenditures. And I've broken down here to the best of my ability how much of each of these funding buckets, what portion of them are restricted or required to be spent on specific activities or programs, where counties are required to allocate some portion of the funding, but it doesn't include a minimum amount. I just estimated 1%. So this gives you a general overview of flexibility currently exists in MHSA funding on the county level. As I've estimated it, it's currently about 49% or about half of all MHSA funding has built-in flexibility for counties to determine it might need to go to a specific component of the MHSA, but what programs and services they spend that funding on does have some flexibility. So with that, we're going to take a brief pause for questions and discussions, maybe about 5 to 10 minutes. Let's see. I'm looking at the time. Okay, we're doing pretty good on time. So let's take a few minutes to answer any questions. And I know some folks have added their questions to the chat box, but if you can, I don't know if we'll have opportunity to like find all of the questions because people have been adding them as we've been going. And I'm wondering if folks can just raise their hand if you have a question that you would like to ask right now. Okay, I don't know if I'm saying the name correct, but it looks like, is it Michael Gayant or Guyant?
Yes, Danielle. How you doing?
I'm good. Can you tell me how to say your name? I don't want to say it wrong again.
It's Michael.
Michael, okay, go ahead.
Okay. Here's what I'm looking for, and maybe I missed it because I'm kind of working in my kitchen. But what I'm understanding about what's going on with MHSA now through the governor's office, and also through with the consult of ex-mayor Steinberg, there's going to be a reduction in, like, for instance, innovation and possibly PEI. Can you address that?
Yes, absolutely. So we're going to address that in specific detail in part 3 of this webinar. So I can kind of just give you a quick overview of my response to that. So that is correct. The PEI services are going to be split into 2 different categories, population-based prevention and then early intervention programs. What the services are under each of those categories are different, and the funding levels allocated to those programs are also different under the proposed legislation. And what was the second part of your question? I'm sorry, you asked about PEI, but innovations as well,
Yes.
right? Okay. Yes. Yeah, and the same thing with innovations. So innovations is going to be lumped together with other funding. So counties will still be able to fund early intervention programs. They'll still be able to fund innovation programs, but the amount of funding that is available for those programs is less, and it'll also be shared with other types of programs and services that counties will be required to fund. So that's sort of a vague answer, but we will get into specifics in part 3.
So this, okay, so this sounds like that with some of the current contracts out there with, like with the latest PEI, sounds like maybe some of those organizations might not make it if this change goes through.
Correct, exactly. And we also in section 3 have specific critiques that the legislative analyst office has provided in doing their analysis of the spending changes. And we also provide some of our own critiques of what the proposed changes might do and the impacts of them. So hold tight and we will definitely get into those things.
Well, great. I'll definitely be there. Thank you.
You're welcome. Okay. Anyone else with a hand up? Sorry, I'm kind of looking through here. Usually the folks with their hands up pop to the top, but I don't always see them right away. Okay, Libby Hardigan.
Thank you, Danielle, for calling on me. I remember when Prop 63 was implemented here in Los Angeles County, and our leadership at the time was really proud that they were able to sort of redefine everything so that people didn't lose their jobs. And I guess my observation about Prop 63 is that there's, I feel this is my opinion, I feel like there was a gap between the systems transformational rhetoric of moving from fail first to help first to the sort of business realities of the providers who just kind of renamed or made small changes so that they could still get the same amount of funding, but there really wasn't a systemic transformation that could make really make our county systems effective. And I'm wondering if you have any thoughts about that. I mean, I'm so happy you're doing this, and I think this information is so much needed I feel I've been going to the quality control meetings now here for years and talking about the implementation of all of these things. And I recognize it's pretty complex, but I kind of feel like what happens is the state says, okay, everybody has to do this. And everybody looks at it and says, well, how can we take this money and just keep doing what we've been doing? Just my observation about.
I share your observations.
Okay.
I'm not sure what else to add that would be helpful at this point, but I think that you and I are definitely on the same page with our observations.
Okay.
I don't know how helpful that is, but.
I mean, I'm really interested in trying to be part of the solution, and it's clear even from what the state legislators said when they amended this act. I think it was in 2020. They said, "Look, we have a broken system." Essentially, said that in those many words. I was like, "Wow, this is coming from our own political leadership." So the issues are visible to everyone, and yet when we try to transform, it's just not. It's like everyone kind of ignores that. It somewhat reminds me of in education, there are trends and the teachers just take the new trend and then just teach the same way they always have. And so I guess that's one of my concerns about the conversation about modernization is really how much difference will it make?
Yeah.
So I guess that's, yeah, thank you.
Absolutely.
If I could comment on that, can you hear me?
Yes.
This is Susan. I just wanted to say that, yeah, there's a part of me that totally agrees with that, Libby, and thinks that, why should we worry too much? Because nothing ever changes anyway, no matter what they do. But I think this issue around cutting the funding for the CSS pot of money and any kind of general system development is going to be an enormous impact on the system, because it will be our whole outpatient system.
Yeah.
And seems to me that specialty mental health would only be really focused on the unhoused and the justice involved. And I really don't think that's the only purpose for the public mental health system. So that, that's kind of my thought on it,
Thank you.
Okay, Gina Lewis.
It was a mistake.
Okay. All right. So how about Sylvia Gonzalez? That's the only portion I can see of your name. Sylvia Gonzalez Youngblood.
Can you hear me?
Yes.
My question is more around like the process and the implementation. One of the things that we kind of struggle with is the idea of how it's supposed to be done. Something that community and community leadership and stakeholders and clients should be the ones actually creating the plan, developing the plan, and implementing the plan. That whatever we decide at the table is what the county has to follow. And I'm thinking, like the other person mentioned, education. I think around education and like the special education local plan here in California, like where we are a part of it, we're part of the process, but it's a collaborative effort. So that would be my question, the process and how much, and I don't want to say the word wait, but that's the only word I can think of, because is it a situation where they could take our input or leave our input, or is our input and ideas and things that we bring to the table truly something that needs to be developed into it? Because right now it seems like the process is community leadership, clients, then the department, then the county. Like there's different groups working on it, and then coming together. So that would be my question.
Yeah. So the way that it's currently, that's the way it's supposed to work. That the counties and the community together are supposed to be identifying, their shared goals and shared priorities to address, community-wide issues that Mental Health Services Act funding can be used to pay for. that doesn't always reflect that in practice. The process has always been advisory, right? So it's not like it's not as if, you know, the community could necessarily veto anything that the county is wanting to do, but it should be a collaborative process. And so that's why, you know, making sure that there's adequate representation of, you know, clients, family members, underserved communities, providers, and other key stakeholders in the process is so important. And also the training aspect is so important as well, because if you don't know what it is that you're providing feedback on, or you don't necessarily understand how it's all supposed to work, then how helpful is that feedback and that participation? So the way that it's supposed to work is to, you know, provide a robust process of stakeholder participation, but it doesn't necessarily always work out that way.
Yeah, and that's kind of where I was thinking, like, again, I'm thinking about education where things are normally in an advisory capacity. And unfortunately, when the language in the law says advisory, well, they could take it or they could leave it, you know, and that's where that communication is. Thank you so much for answering my question. I appreciate that.
You're so welcome. So I do have, like, I want to maybe throw this out here to other folks, because it sounds like there's a lot of interest, and many folks on here are very, very, I love that you're jumping into the details, okay? And I want to be able to get to those details. I'm worried that we might end up going past 1:30. As I mentioned, this is going to be recorded, so we can stay on as long as necessary, but I want to also recognize that other folks may not be able to. Maybe we can take like a brief, like, you know, unrepresentative poll in the chat and let us know, you know, do you want to move quickly and try to finish by 1:30, or do you want to, you know, do you want me to be able to take more questions?
Danielle, can we call on Wendy? Because I know she's had her hand up for a while.
Yeah, there's one person ahead of Wendy, and then we can get to Wendy. So I was just trying to figure out how many more folks I can get. All right, folks want to move quickly. All right, I'm going to take two more folks. So Jerry and then Wendy, and then we're going to move on. Go ahead, Jerry Hall. Oops, sorry, let's see. Jerry, we've unmuted you, but I think you're muted on your end. So if you would like to talk, go ahead, or I'm going to move on. 5, 4, 3, 2, 1. Okay, Wendy, it's your turn.
Oh, thank you. Thank you. Just quickly, where are these vouchers coming from if MHSA can't supply them? If the MHA is not the source, where are these housing vouchers coming from?
It's in another part. Claire's going to be handling the housing component in the next webinar of the series.
Yeah,
I don't actually know, so I'm sorry.
Okay. That's okay.
I'll
That's okay.
jump in and just give you a real quick answer to that, Wendy. Under the different funding components, both innovation and CSS, there are different provisions that allow MHSA money to be spent on housing. And then you have to ask what that means. Sometimes it is rent vouchers, sometimes it's buildings, sometimes it's utility payments, sometimes it's infrastructure of certain types. It's a big
Cool.
not well-defined mix, but we will get to that, and you know, whether SB 326 is actually going to expand giving people vouchers, or what the heck housing actually means in SB 326.
Okay, thank you. Thanks. And who was that talking? Who was that?
That's Claire Courtright.
Oh, thank you, Claire.
Could we try again, Danielle, please?
Yeah, go for it, Jerry.
Okay, quick. Sorry, I'm on my phone. Thanks to Cal Voices for doing this. I really appreciate it. I think a lot of the questions could be answered, and a lot of these issues could have been avoided had the counties actually had a process where a CPP process where the advisory board got to review and approve the process the counties took to create the plans and the budgets and all. And I think what we really need to do is to, and I'll just cut to it quickly because I have a lot of arguments, obviously, but I think it would be really helpful if we had another webinar that just focused on the CPP and the intent of the idea that the stakeholders are supposed to be driving the decision making. And I think it's, even though it's advisory, politicians are very, in tune with voters, and the fact that we really don't have a voice because the CPP is really ceremonial in most part around the country, around the state. And that I say because out of $106 million from fiscal year 21-22, we spent $6 million on CPP activities. So we left over $100 million sitting on the table. So I think there's a definite need to talk about the fact that these 3-year plans are not really plans, they're more reports that just tell us where you're going to spend the money. It's not really what are the challenges, what are the solutions, what are we going to try, what it's going to cost, and then next year we evaluate all those decisions and then adjust. So I think what we have is we have 3-year reports where the BHS is just telling us where they're going to spend the money, and it really needs to be more of a plan that really articulates challenges and solutions and opportunities. Thank you.
Yes, absolutely. Thank you so much, Jerry. Agreed. So we're going to go ahead and move forward. We do have a lot to cover. It looks like the general consensus is that people want us to move quickly. So we are going to give the people what they want. Okay, so part 2, the origin of the current efforts to modernize the MHSA. We figured that folks would need a little bit of some orientation as to how we got here. And I'm going to go ahead and let Claire take over this part. So we're going to do a quick switcheroo here. One sec. Yeah. Okie doke. How do I do this? So the origins of MHSA modernization, it's been a process over time affected by a number of different actions along the way. A 2008 Department of Finance MHSA performance audit, the passage of the Affordable Care Act, which expanded who was eligible for Medi-Cal in California, passage of AB 100, mental health realignment funding, which changed how some of the funding was dispersed to counties or transferred some responsibilities to counties. And then there was a regulatory change. The Department of Mental Health was dissolved. And broadly speaking, the Department of Healthcare Services took over quite a bit of that. Little Hoover Commission and the California Auditor reports on the MHSA in 2019. And then 2017 to present, what's really driving this, politicians are disclosing. There is obviously a crisis of houselessness in California. There are people who are very invested in only focusing on that portion of the unhoused population who may have an untreated mental illness or a substance use disorder. But there's been quite a bit of evidence lately, especially UCSF recently did a study, largest study on the unhoused population since the mid-90s, showing that, really you're talking about maybe a quarter of the unhoused people have a serious mental illness. Maybe somewhere on the order of 30% are using substances. And, that doesn't necessarily mean these people are completely unable to take care of themselves or direct their own lives. But there's a narrative that says, houselessness in California is about serious mental illness and substance use. And there is so much tremendous pressure, both within California and really nationally, that California do something about what's happening here, that all of this has arisen. And so I would say, broadly speaking, a number of bills, things passed last year, like Care Court, things passed the year prior, like the expansion of AOT. This year, the expansion of conservatorships, making them easier and a lower standard, and including for the first time people with substance use disorders can be placed on involuntary holds and conserved. And then a enormous number of changes to the entire behavioral health system, public behavioral health system, that is really just zooming in on this issue of unhoused people. And it's going to necessarily happen to the exclusion of other things. Okay, that was too much talking. Next slide. The rates of homelessness in California, as everyone is aware, have risen very steeply, especially since the pandemic. And again, this UCSF housing study that recently came out told us why. And it was the double whammy of people losing income due to job loss, due to COVID, and inflation in general, and housing cost inflation in California, which is a function of there not being enough homes, especially not being enough affordable homes. And so, you know, looking at the situation, a lot of people will admit, yes, we have a housing crisis in California. And so, you know, refocusing everything we're doing on the unhoused population with serious mental illness or a substance use disorder is really leaving out a whole bunch of folks who remain unhoused, and somewhere around 70 to 78% of those people who are unhoused are unsheltered. So again, even the focus on encampments, we're sort of assuming that the only people that live in encampments are people with substance use disorders or mental illness. But statistically speaking, the numbers being what they are, it's many people who have neither. Further changes, so many changes. In 2019, there was the introduction of the CalAIM proposal, and CalAIM was a number of changes to the Medi-Cal program. That could be a webinar in itself. And there are some small places where the housing pieces we'll talk about are overlapping with goals or partially funding some of the housing programs they want to provide through CalAIM. So there's a lot of crossover. And I just want to pause and emphasize too, there's definitely a grand scheme here. There's a number of coordinated bills happening. There's been a number of major reforms happening or changes to existing programs. And some person or set of persons in the administration and in the legislature do understand how this all fits together. But there are not clear, comprehensive statements of it out there at this time. And to tease it out from, you know, bits and pieces of changes to, you know, 69 statutes is incredibly difficult. So we're, you know, the community is in this very rushed process to cobble together as much of an understanding as we can from doing a lot of legwork while we're still waiting for the administration to tell us, okay, well, how do all these things fit together? You know, how do the new housing spending buckets in SB 326 relate to Care Court, AOT, conservatorships? Are they housing vouchers? Are they permanent supportive housing? What about No Place Like Home? Weren't we supposed to build some housing? What about all these homeless initiatives that we've spent $20 billion on? What about the, you know, opioid settlement money? There's a huge ecosystem going on here, and there is coordination, overlap, and intentionality behind it, but the community is just not getting a lot of transparency as to what it is. So that was a sidebar. So 2020 to present, there's been a massive push to expand involuntary treatment. I tend to call it involuntary interventions because some people don't find it to be treatment. So just in recent years, and running up to this big change in how we're going to spend money, there was AB 1976, and what that did was AOT was previously the counties had to opt in to have assisted outpatient treatment programs. That was changed in 2020. Now a county has to opt out or they're automatically in AOT. So that was a very extensive expansion to AOT to counties that said, you know, we don't want to do that. In 2021, there was an expansion of the AOT criteria. And then, of course, famously last year was SB 1338, the CARE Act, which is court-ordered, quote unquote, care plans that include a number of features, including, you know, medications that you have to take, services you have to engage in, and what they're calling a housing plan. And so because Care Court really hasn't been implemented yet in any county, we don't know exactly, you know, especially the housing plan piece. We don't know if that means the court's going to say, look, you have to live here. And if you don't follow your care plan, then you're failing out of Care Court, and it creates a fast track for you to be conserved or placed in a hospital. So I think what is happening here that's important to notice is that we've created this kind of in-between. So you had, you know, traditional, very restrictive programs like conservatorship, under which you could be placed long-term in a locked facility, under which people are placed in IMDs, state hospitals now. So that is kind of what we've thought of as institutionalization traditionally. But now we have all these court-ordered outpatient treatment plans that, you know, maybe it's not being in jail, but it might be house arrest, because there's a lot of things that you must do, things you must engage in, including housing pieces. And so when we talk about housing, you know, one of the things we're going to talk about is, you know, are we moving funds from true housing and voluntary services, and are we going to use them for court-ordered things in this in-between quasi-institutionalization of AOT and Care Court? And then also in 2022, there was a large federal award to California of funds for the continuum of care projects to address homelessness. There, I mean, it just goes on and on. There's also a number of infrastructure programs that the state has started and given funds through, or are planned. You know, there's another bill moving through the legislature, SB 45, that allows the state to make loans to build locked facilities. Again, too much to say. So Governor Newsom's fact sheet on modernization is proposing a major transformation to the state's behavioral health care system. So this is really every aspect of it, right? It's the court-ordered programs, it's funding, it's what we're building, for whom, you know, where. And so part of this effort is you're going to hear about AB 531. It's the governor's bond measure, which lets the state borrow money to build things. This is not MHSA funding. This is a general obligation bond. It would be paid back with general tax revenues. So this is not funding source from MHSA, but, you know, originally in the sort of advertising for this, we were told it's going to be scattered site cottages, you know, voluntary unlocked was really emphasized. And then, you know, when they amended the language to kind of tell you more about what they were doing quite recently, it turned into, okay, well, you know, about 4 billion of the 4.68 billion is going to go to build 10,000 new beds. And the nature of those beds is not clear because they use casual language and don't, you know, talk about a license class like an acute psychiatric hospital, an MHRC. So we don't really know, but we know it's beds and not typically what this community would think of as true housing. And so, you know, the MHSA amendments have to go on the March 2024 ballot. Also on the March 2024 ballot is this AB 531 bond measure, which again, even the language to is still being amended, and it's really going to go for treatment beds of some type for substance use and mental health conditions. We can skip this. We'll talk about this in the next section. Same thing. Okay, so again, just a separate slide on AB 531, what we're talking about, the bond. When we talk about housing, I'm really going to try to simplify it as much as possible. And so, you know, subsequently we'll talk about, okay, is housing, is it kind of like cash assistance, like a rental voucher to an individual, or are we talking about buildings, buying them, building them, rehabilitating them, allocating costs to run them? And so for AB 531 for the bond, this is just about buildings. Nobody's getting a housing voucher out of AB 531. And again, you know, the overwhelming majority of this money is going to go to build treatment beds, and we don't know of exactly what nature at this time. So one of the things that SB 326 changes is the requirement for voter approval. So MHSA again was passed by the voters through a ballot initiative that was introduced by California citizens. It included the following provision: the act shall be broadly construed to accomplish its purposes. All of the provisions of this act may be amended by a 2/3 vote of the legislature, so long as such amendments are consistent with and further the intent of this act. So essentially, to like decode that, what it means is if you're going to change the MHSA, but you're changing it in such a way that it's really consistent with its intent, goals, and mandates, then the legislature can do that by a 2/3 vote. But if you're trying to make some big fundamental change to the MHSA, you cannot do that by a 2/3 vote. If you want to make a big fundamental change to the MHSA, it has to go back to the ballot. So that's why SB 326 is both a piece of legislation and it is a ballot initiative. So if that's not clear to anybody, what's happening is the legislature is voting on language and provisions that are going to form a ballot initiative, and voters are going to be able to vote on any part of SB 326 that actually affects the MHSA. Again, there's a ton of stuff in 326 that is not an MHSA amendment, does not have to go to the ballot, and it's just going to be passed into law if SB 326 is passed through the legislature. So again, just what I covered, you know, if they wanted to make a change to MHSA that is inconsistent with the act, or the amendments don't further the original intent and purpose, got to take it to the ballot. Also, per the California Constitution, the legislature may amend or repeal an initiative statute by another statute that becomes effective only when approved by the electors, unless the initiative statute permits amendment or repeal without the electors' approval. We're going to skip this because I'm talking too much. All right, we're going to switch around here again, guys. And I recognize that folks need to get done by, we have 15 minutes. So I'm going to, this is probably the most important part. So I'm going to speed through this. Sorry, guys, but we'll go ahead and get you the slides. And then we will have our we can review a little bit and answer any questions after that. So part 3 is how SB 326 changes the MHSA's program and expenditure requirements. So just a quick recap. The current MHSA revenue allocations, out of the total revenues collected by the state, 5% go to state administrative agencies and 95% goes to the counties. When the counties receive that funding, they must allocate 19% to prevention and early intervention programs, 5% to innovative programs, and 76% to community services and supports, which also pays for other expenditures. We reviewed this before, like what the breakdown actually is of the different expenditures in each funding bucket. And this was my, quick back of the napkin math on how the funding currently breaks down for the different programs and expenditures under the MHSA. So let's talk about how SB 326 changes the MHSA's program and expenditure requirements. So first of all, let me give you a quick overview of SB 326 itself. It changes the name to the Behavioral Health Services Act, or BHSA. Okay, so when I'm talking about what SB 326 does, I'm going to be saying BHSA because it's going to take the MHSA money and use it for different things. It reduces BHSA revenues allocated to the counties from 95% to 92%. It allows BHSA funds to be used for standalone substance use disorder services. It shifts the majority of county BHSA allocations to two funding categories: FSPs with new criteria. So full service partnerships will still be in the act, but the criteria to be in an FSP will be new. And then also housing interventions. The FSP funding category prioritizes people who are served in assertive community treatment or forensic assertive community treatment and substance use disorder treatment programs. So folks who are participating in interventions under AOT, conservatorships, or care court. It removes the PEI funding category and it creates a new population-based prevention funding category that may not be used to provide services to individuals. It lumps funding for early intervention services, innovative programs, and other expenditures, so capital facilities, workforce education and training, and prudent reserve, into one smaller funding category of behavioral health services and supports. It eliminates the current non-FSP CSS programs and services under general system development and outreach and engagement. And it also requires programs and services funded under the BHSA to maximize Medi-Cal reimbursement and other matching funds to the greatest extent possible. So visually, what does this breakdown represent? So again, 5% of all revenues, the actual tax amount collected doesn't change, but how it is broken down, how it's allocated does. So 5% will continue to go to state agencies. 3% will go to a new statewide workforce initiative. We're not getting into that in this webinar. There's just not enough time and there's too much to cover. And then 92% of all BHSA revenues collected will go to counties. The breakdown of county BHSA funding allocations is going to be 5% for population-based prevention programs. Again, that does not include individual services. 30% to housing interventions, 35% to FSPs with new criteria as to who is prioritized as an FSP, and then 30% to this kind of catch-all category called behavioral health services and supports. So 92% of BHSA revenues go to counties. We mentioned what those programs were, so I'm not going to go into them. Additional allocation requirements. So the breakdown of the breakdown, right? So the population-based prevention programs is 5%. Housing interventions is 30% of county BHSA revenues. At least 50% must be used for chronically homeless individuals with focus on folks who are in encampments. No more than 25% of housing intervention funding may be used for capital development projects. Up to 2% of the entire county BHSA revenues may be spent on internal, like quality assurance and quality improvement, evaluation, reporting, and compliance activities. And it keeps the funding allocation for the annual planning costs up to 5% of the total annual county BHSA revenues may be spent on the community program planning process. 35% must go to FSP programs, and then 30% or the rest of it goes to behavioral health services and supports and other expenditures. The majority of the behavioral health services and supports funds must be spent on early intervention programs. So that would provide direct services, but it would only provide direct services to people who already have a diagnosis or a first incidence of an illness. And the rest may be spent on workforce education and training, capital facilities and technology, innovation programs, and the prudent reserve. And it creates a new cap for the prudent reserve, which is 20% of the 5-year average of the county's Behavioral Health Services Act funds. So I know this is bombarding you with a lot of information, but I want to get through this so that you have the information you need. So again, a visual breakdown of that, right? You have the population-based prevention, which is 5%. You have housing interventions, which is 30%, and it breaks down into different, funding categories within that. The 50% must be spent on people who are chronically homeless. And then you have FSPs at 35%, and then behavioral health service and supports, the majority, or let's say 51%, needs to be spent on early intervention, and the rest. So right here, when Michael asked, what about prevention and early intervention and innovations? That's where this funding is going to be coming out of. If you want to do early intervention early interventions here, but other prevention programs that are not population based would come out of this funding stream. Innovation programs would also come out of here. Capital facilities and technology, workforce education and training, and your prudent reserve allocation would all come out of this smaller slice right here. So I did another, breakdown for you, for the math nerds out there, to look at how much of the funding under the SB 326's Behavioral Health Services Act allocation methodology, how much of it would be restricted versus flexible. And as you can see, this is just, again, this is just sort of my back of the napkin calculations based on what information is currently available in the pending legislation. It looks like about 66% of all of the county funding will be restricted, and only about 33 or 34% of county funding will be flexible, and flexible within specific categories. So this is a side-by-side. You guys will get this when we distribute the slide deck for you. So quickly, I'll go through some of the issues brought up in the Legislative Analyst Office analysis of SB 326's funding changes to the MHSA. So the Legislative Analyst Office brought up the fact that the administration's justification of the proposed changes is incomplete. So under the proposal, counties would need to increase MHSA expenditures on FSPs and housing while potentially reducing outpatient services, crisis response, prevention services, and outreach. The administration has not provided an assessment of how these changes may negatively impact current services. For example, while the administration cites a shortfall in psychiatric treatment beds as a primary justification for the focus on housing interventions, the administration has not provided the rationale for using MHSA, given the trade-offs, to address this and other issues. Consequently, as the legislature considers the proposal, we recommend asking the administration certain questions to assess whether the proposal is warranted. Would statewide behavioral health outcomes be improved by shifting funding focus? So while research supports the administration's proposed interventions to improve outcomes for individuals experiencing or at risk of homelessness, MHSA services benefit a broader population of Californians. Consequently, some beneficiaries of MHSA may no longer receive certain services under the proposal. On net, can the administration provide evidence that the proposal is likely to result in better behavioral health outcomes for the population as a whole? Why does the administration propose using the MHSA as opposed to other funds to support the priorities reflected in the proposal? What are the trade-offs in reducing county spending flexibility? The administration's proposed funding categories would reduce the amount of overall flexibility afforded counties. In effect, the proposal would shift the discretion in setting MHSA funding priorities away from counties to the administration. This potentially deprives the state of county-level expertise in program implementation and understanding the needs of its residents. The legislature may wish to ask the administration, along with counties, about the trade-offs of reducing county flexibility in MHSA spending. Additionally, the legislature should consider whether the shift towards a top-down approach in the use of MHSA funds aligns with the legislature's vision of the program. How does the proposal complement recent initiatives to serve individuals experiencing homelessness and behavioral health conditions? The proposed housing interventions category includes a requirement that the majority of funding be for services to individuals who are chronically homeless. The administration has not yet sufficiently articulated how its proposal complements a recent major initiative approved by the legislature, the Behavioral Health Bridge Housing Program, to provide housing supports to homeless individuals with behavioral health conditions. So there's not sufficient tie-in and agreement with other legislative efforts. And then what are the impacts on individual counties? Our analysis, or the Legislative Analyst Office analysis, evaluates how the shift in funding categories could impact county expenditures at the statewide level. However, as noted, the actual impact to individual counties can vary. The legislature could ask the administration, along with counties, for information on the anticipated distributional impacts of the proposal on a county-by-county basis. This information would give the legislature a more comprehensive picture of local impacts. Now for our critiques, right? This is what you've all been waiting for, I'm sure, right? So our critiques are as follows. So SB 326 was dropped on the public just over a month ago, and it was drafted without any meaningful involvement of clients, consumers, peers, providers, and other key stakeholders. The legislature is jamming this bill through to get it on the March 2024 primary ballot, which limits meaningful public participation. SB 326 fundamentally restructures the MHSA to pay for court-mandated treatment imposed under the CARE Act and to prioritize other involuntary services in response to recent and attempted expansions of AOT and conservatorship criteria. All right, so this is the big thing here. The whole reason for restructuring the MHSA is to pay for these expansions in involuntary interventions. Additionally, it emphasizes medical model treatments and interventions and prioritizes services that are Medi-Cal reimbursable and not necessarily recovery-based. It reverts back to a fail-first approach. It betrays the MHSA's original purpose and intent by shifting the bulk of the Act services and funding toward involuntary treatment. It spreads less funding more thinly by including coverage for standalone SUD services, but it does not include non-supplantation requirements for current SUD funding, right? So if you remember when I talked about the MHSA when it was enacted, it has a non-supplantation requirement that counties and the state cannot cut current levels of funding for mental health services. So the MHSA is not supposed to be used to backfill funding cuts in other areas. That non-supplantation requirement for SUD services is not included in SB 326. These changes will disrupt existing voluntary services and supports for children, adults, and seniors with SMI and SED, especially current FSP clients. Elimination of funding for PEI prevention services for individuals, for CSS general system development programs, and CSS outreach and engagement services will cut existing and future programs that provide crisis intervention and stabilization, peer support services, because that comes out of general system development, peer support, family education, and wellness centers, okay? And there are currently peers, the way that that peer certification is structured, peers can only bill for their services if they're working in a county system. So not like, you know, community health workers who can work in private systems of care. They must be working in a county-based system. So funding for peer support services that are currently under these MHSA categories is going to be going away. So unless there are complementary services or funding in other areas of the SB 326, there's a big possibility that these services are going to be cut, and then a bunch of peers who have become certified may not have options to go work in other systems. Services for traditionally and underserved communities will be impacted because these Funding categories address services that include alternative and culturally specific treatments, outreach to cultural and faith-based communities, and strategies to reduce racial and ethnic disparities. It will also impact system transformation and client and family advocacy activities that are funded through general system development, and also cross-system outreach and collaboration efforts that work with CBOs, schools, the child welfare system, criminal justice and juvenile justice, foster care, tribal communities, primary care providers, and faith-based organizations. Funding for those activities looks like it's going to be drastically reduced under the current proposal. And then finally, SB 326 and these interventions are not going to substantially reduce California's unhoused population. Why? There are currently, as of the last HUD point-in-time homeless count in California, 171,521 unhoused people. Among them, just 23% have SMI and 17.5% have a substance use disorder. And we know that some of these will overlap because they don't count co-occurring separately. So even if 40%, if we add up these two numbers, right, even if at 40% of unhoused individuals will qualify for housing and other interventions under SB 326, 60% will not. And the numbers are going to continue to grow because it doesn't tackle primary root causes of homelessness, which are lack of affordable housing for low income and disabled individuals. So it's like a leaky bucket, right? You're putting, more funding towards something, but it's leaking out because we're just adding more and more and more individuals who are becoming homeless by not addressing the root causes. It also conflates, severe mental illness and substance use disorder and homelessness, and then it only addresses half of the problem. It doesn't recognize the fact that being unhoused, just the fact of being unhoused, often creates or exacerbates underlying SMI and SUD. So it's a two-way street. You don't just become unhoused because you have SMI or SUD. Often you develop SMI or SUD because you are unhoused. And then it doesn't prevent individuals from developing SMI or SUD that may later contribute to them becoming unhoused. All right, so that's the meat of it. And we are a few minutes after. And so everyone who has been on this will receive a copy of the slide deck, but we'll go ahead and whoever wants to stay on with their questions, anyone else can leave if you want to, and we'll send you the slides. But if you want to stay on and ask your questions, then feel free to do so. And if you are interested, please raise your hand. And Steve McNally, your hand has been up forever. So if you are still interested in talking, you are unmuted. Go for it now, sir.
Oh, hi, this is Steve McNally. It's because I forgot to take my hand down when you said you only had two people and Jerry went. So I put my comment in the chat about, look, if you'd looked at the annual revenue and expenditure reports to find the community planning figures and also the federal funds participation rates, which a lot of what's driving this is Medi-Cal reimbursement. And that varies dramatically across counties.
Yes.
So, and then, I mean, it seems to me that the LAO report came out after they're so far moving ahead. What do you want us to do? Like, or do you have two pagers we should take to our legislators? What is it that we can do to empower the audience to act?
Yes, absolutely. Thank you. That was in the part that we didn't get to yet. So no, that's okay. But I wanted to respect, will the recording be available as well as the slides? Yes. So sorry, guys. I'm trying to handle all of this stuff because I want to make sure you guys get what you need to get.
And let me say one last thing. The only good thing is so far is that now we can have a headline that says Darrell Steinberg endorses taking away $700 million plus from mental health. I forgot. And the second headline is Jessica Cruz at NAMI endorses taking away mental health money. That's so far the best comic relief I've gotten out of the whole thing.
All right. Well, we are definitely so one of the next steps and action items that we weren't able to get to because I recognize that folks need to leave is that we are going to provide resources for you to contact your representatives, and we're also going to create a sample letter that you can obviously it'll be editable, so you can add or remove whatever it tickles your fancy, but we will be providing a sample letter as well. Sorry, Claire, did you want to jump in and say something? No, okay, my bad. I was misinterpreting the signs. And let's see here. It looks like Mark Carmatz has their hand up, so I'm going to unmute you now if you want to go ahead and talk. Hello, Mark. All right. How about Mary McCauley? Go ahead.
Hi, could you post somewhere on here where we can see it, how we get the slides and the letter, because I'm not figuring that out.
We have not developed the letter yet. The slides we will send out to everyone who has registered. So we will send it out after the webinar is over, and it will include additional information on next steps and action items. Additionally, we will be sending out another email blast to register for the next webinar in the series that's going to happen in 2 weeks. And we will include in that email blast the attachments to the recording and to the slides for this webinar.
Okay, so when you're finished with the letter, how do I get it?
We will send a link to you with it, or you can just email us if you, for whatever reason, you don't have it. You can send an email to one of us.
Okay, and are you gonna put your email addresses in the chat?
Yes, I will do that right now.
Okay. All right, thank you. That was my question. I'm all set.
And thank you all for bearing with us, because it really threw me for a loop when we were having like some of these issues when we were trying to start here. Okay, so Mark, I've unmuted you, but I don't know if you still want to talk. Mark Carmatz. Okay, Michael, go ahead, Michael, if you would like to.
Go. I mean, this is a great presentation. This is something that I've been waiting for a while. I plan on being in all the webinars. But one of the things that alarmed me that I kind of missed, because I stepped away from my computer, is this is going to impact peers, especially the newly certified, state certified peers. Can you briefly, as quickly as you can, explain that again?
Yeah, so currently funding for peer support services under the MHSA is under the community services and supports component under general system development. Okay, so under the changes to this funding under SB 326, that general system development funding category will no longer exist. So there won't necessarily be a dedicated place where peer support services can be billed under the new SB 326. It doesn't necessarily mean that all peer support services will be going away. We just don't necessarily know. There's not a dedicated, requirement or specific funding category that they can be billed to. So it could potentially impact, it certainly will impact peers who are not certified. I can tell you that, because at least peers who are certified will be able to bill Medi-Cal if they're working in coordination with other, treatment programs that will be like serving FSPs and other clients that are eligible for services under these changes. But the amount of funding for standalone peer support services, especially places like wellness centers that may not necessarily be connected, or they might not be part of like a multidisciplinary program where they have clinical supervision right on site, those might potentially be impacted because it's very unclear how they will be continued to be funded under SB 326's changes. The problem with that is that the way that peer certification is currently structured in California, peers can only bill for services in especially mental health and drug Medi-Cal programs. Only counties are providing those programs right now. So it's not like you can go work as a peer in Kaiser, you can't go work as a peer in some other private setting, because unless they're providing specialty mental health services and drug Medi-Cal, and the way that it's structured in California, that's not really an option. So the problem is that peers are locked into the county system, certified peers are locked into the county system, but the potential funding for their services could be drying up or reduced under these new changes to the MHSA. So we don't know what's going to happen. But with the prioritization of clinical interventions, we can guess.
Yeah. Well, it's that's sad. I know a lot of people going in for the certification. I finally decided that I'm going to, but I don't have a need necessarily as far as my, as a vocation. I'm taken care of in that respect, but I'm concerned for the many of the people that I know that's going for the certification and has gone for the certification to look for an opportunity, to work as a peer.
Yeah, exactly.
And I'm alarmed to hear that Jessica Cruz endorses this.
Hey, you guys said that. I didn't say that.
I'm just going by what I heard. Thank you.
You're welcome. Okay, Tiffany Elliott.
Thank you. So I know that NAMI's been a really big proponent for this, this whole movement for a while. And that there was some pushback when it came to light that PEI was going to be touched. Is PEI still strongly on the table? I wanted to double check about that, and if that might be an avenue to approach when it comes to talking about this, the negative impacts of this, and maybe turning the tide.
So I'm sorry, just for clarification, when you say is PEI still on the table, what do you mean on the table?
For cuts, for significant cuts.
Yeah, so the way that it's structured, I would say yes. So let me see. Let me go back here, see what I can find out. Oops, my bad. Okay.
They've just been so unclear about the budget with all this, and over again, it's been changing. So I wasn't sure anymore.
Yeah, no. So based on what's currently in the proposed legislation, it looks like you'll have this population-based prevention funding bucket, right? That's 5% of the county's BHSA expenditures. And then under, under behavioral health services and supports, counties will have to spend at least 51% of that funding bucket on early intervention. So early intervention means actual services for people who have a diagnosis or early onset of a diagnosis, right? And this population-based prevention is not services. We know that it is not services, actual, prevention services. It's more like, I don't know, like education, like public education and things like that. It's not necessarily identifying people before they are diagnosed. So
Diane, do you want to let, I don't know if we can unmute Stacy for a minute. She wanted to say something
Stacy,
about the
okay,
PEI. She's on here. Yeah, thank you, Stacy.
Okay, let me look. Stacy, can you raise your hand so I can find you to unmute you? There you go. All right. Go ahead, Stacy.
Thank you. This is, if you'd permit me, this is the part that REMCO, the Racial and Ethnic Mental Health Disparities Coalition, really cares about. And the total amount for PEI would be around the same, but the problem is they are shifting from, group prevention, things that are not evidence-based, to more clinical, like early psychosis identification. That it will be the emphasis more than the community-defined evidence practices, which could include a lot of consumer programs, because some of the consumer programs are group and, they are not, quote, evidence-based yet. So, yeah.
Thank you so much, Stacy. That's really interesting to know.
Yes.
Thank you so much, Stacey. I appreciate it.
No, thank you. You guys are great.
No, absolutely. There's just so much to cover, and it's so hard to drill down into like every potential, impact of this. So we're definitely relying on everyone else here, because I'm sure we're missing things, or, things that don't necessarily stand out to us may stand out to you. So thank you so much for adding that. I appreciate that coming in clutch for me there. Let's see. So Tiffany, did that answer your question? I don't think that it necessarily did.
It did touch on it, but
okay.
yeah, I'm just wondering if that's a way that we might leverage with NAMI, because I know that having their name behind it, the National Association on Mental Illness, that's really big. So if we could turn the tide there, that would be helpful.
Yeah, I mean, I think that the hard part is that and this, like folks have different priorities, and they focus on different aspects. And I think a lot of us here from peer-run organizations or that identify as consumers, we're particularly concerned about the impacts, the involuntariness and the focus, the shift to medical model, and not de-emphasizing recovery and things like that. Whereas folks who are struggling with family members who have been unwell for a long time have different priorities, and that's hard. So that's all I'll say about that.
Well,
Wendy, Wendy, go ahead.
Yeah.
Sorry, Wendy, you're still muted.
I said, thanks. Okay, can you hear me now?
Yes.
Oh, okay. I said I wanted to share what I wrote in the chat because it went to the host and the panelists, and I didn't realize that. But this is something that has been bothering me for a while when I was in my 13-year homeless journey. And now that I've come out of it, I'm still trying to figure out why it took that long. But in other words, I was saying, for those who don't meet the HUD definition of chronic homelessness, living on streets and encampments and vehicles in the desert and motels, one or a family who recently becomes homeless are sitting at the back of the line, feeling ignored and overlooked and deteriorating slowly till death, voluntary or involuntary, due to feeling overwhelmed and hopeless and not having their basic needs met according to Maslow's hierarchy of needs. Without proper housing that's safe and conducive, people who were once productive and contributing to society now have become part of the statistics due to no connection to PEI support, because priority is on those who've been on the streets the longest. I understand this particular subpopulation has many needs that require extensive support and resources, yet the reality remains by the saying that says, you can bring a horse to the water, yet you can't make it drink. Then decision makers expect this special group to act civilized when given housing. And it's just like a food for thought.
Yeah, I mean, I don't know what else to add to that, because, we all know that it's really important to make sure that programs and services are meeting people where they're at, right? And that it's a two-way street, and that you're building trust and that it's relationship based, right?
Yeah.
And that is being de-emphasized because this is a political solution to a health problem.
Can we call it out like it is?
You could do whatever you want. You can say whatever you want.
Because I want to know.
Still,
I want to know. I want to know when's the last time these legislators have walked the streets.
Well, if you listen to some of them, they see the same person on the street every day. I don't know, but I don't know if I think the bigger question is, when's the last time they talked to somebody who's recovered?
Okay, that's fine too.
Yeah.
Okay, let's do it. Thanks.
So there was a question in the chat that I just happened to catch because I happened to be looking over, and that was, will everybody get the slide deck, everyone who registered? Yes, we will send out the slide deck to everybody who registered. And Hector, you have had your hand up for a long time, so it is now me calling on you.
No, thank you. Happy Disability Pride Month, everybody. This was very informative. I think in addition to what has already been said, and I think Stacy, I really wanted to go back to what Stacy also brought up, because this is supposedly, this new housing is supposed to have like a population element that's supposed to like enhance certain populations. And I just wonder if that's really the case, because we know that our equity seeking populations, in addition, our Latino, our Native American, our API, our Black, our immigrant, our LGBT are the ones that are still really not benefiting from the MHSA like they were supposed to. And I'm just really wondering if this new modernization will do that. I wasn't sure, and that was one of the many things that I have been concerned with this movement.
Yeah.
And thank you for clarifying what you did share and didn't share.
No, absolutely. Thank you for asking, Hector. And one of the things that we weren't able to get into is that I think under FSPs, there are a bunch of new target populations that are also supposed to be prioritized for services under FSPs. But the big thing is that, okay, so you have all of these priority populations that include like racial and ethnic minority groups, and other traditionally, marginalized and underserved or unserved populations. But again, the services, though, it's like great that you're going to serve all these populations, but if the services are primarily focused on AOT, assertive community treatment, and potential other court-ordered services, then how much room is there to provide voluntary services for those populations, right? And that becomes the question. And that's certainly something that we can potentially look at in future webinars. But even if you prioritize specific populations, if the services that you're offering them are involuntary or primarily involuntary, then what good does that actually do?
Yeah,
that doesn't sound very person-centered, which is the approach that we have been really working with the governor to do. But you're right, having access, quality, and outcomes depends on the services that we need.
Right, exactly.
Yeah, and just to chime in with what Danielle said, yeah, the new FSP sections actually say, if somebody meets this demographic, they must be enrolled in an FSP. And then, again, we're going to look really closely at what those quote unquote housing intervention funds can be used for, and whether, that could potentially be people losing voluntary housing through an MHSA housing program now, so that it could be used for involuntary housing placements under a variety of programs. And to Hector's point too, I mean, if you just want to be ultra simplistic about it, we're shifting $1 billion out of services, and at the same time expanding the population that is supposed to be served. And then on top of that, there's a bunch of mandatory spending that isn't services. And at a certain point, whether it's when something is enacted and we start to see it play out, or we're all able to digest more of this elephant and tease out the pieces for ourselves. But I think, the legislative analyst's office really said it, there's a significant decrease in the flexibility and ability of counties to provide services, to provide particular types of services, and how tight that squeezes, I don't think anybody quite knows yet.
Yeah. Jonathan San Juan, you have had your hand up for a long time.
Oh, hello.
Hi,
Is this Claire or Danielle?
this is Danielle.
Daniel, so I primarily work on evidence-based practice called Wellness Recovery Action Plan. And also I'm working on the Psychiatric Advance Directive. Our county in Contra Costa is, they're really dedicated to RAP, I would say. What would, and RAP is prevention, early intervention, and Psychiatric Advance Directive would be, I think, an innovation. What would they change their funding for these services? How would that look if 326 were to pass? Would these services be continued? Because they're primarily peer services, I would think.
Yeah, yeah. So I would say that, like, so if we're looking at where it could potentially be funded under SB 326, right? So if we're looking at early intervention population, so maybe folks who, you know, have, we're intervening early in the onset of their illness, right? Like maybe right after they've been hospitalized, or, you know, they've just had, you know, a significant episode and they've been diagnosed. If we're doing a RAP group, you know, or providing peer services, that might come under early intervention, under behavioral health services and supports. It wouldn't come under population-based prevention because groups would be an actual service, right? So it wouldn't come under this population-based prevention. It could, if we're working with like a multidisciplinary team with FSP clients, it could potentially fall under that, you know, peer support services on multidisciplinary teams for people with, you know, SMI or SUD are Medi-Cal reimbursable. So if we're doing RAP, individualized RAP plans, or doing peer support services with RAP groups or something like that, I would think maybe it could come under FSPs. So it really just depends though on how the county decides to structure its services with these funding changes. So it seems like there are possible ways for the funding to continue. It's just, what does that mean as far as how counties are prioritizing funding for other things, you know, based on the new limitations that are provided under this legislation. Does that make sense?
That makes sense. So PAD is Psychiatric Advance Directive is an innovations thing. Would you kind of give that the same review, that it would still be there, but depending upon our county's plan to redistribute, what would that be a greater difference? Because it's
I would say, well, I mean,
I can't quote the specific language because again, I mean, every time I look at this, it just gets more complicated. But a secondary source, I was listening to Michelle Bass from DHCS the other day, and the way she explained it is, yeah, okay, so the innovations bucket as we know it is now gone, but actually you do have the ability under different community supports and services functions to do things that qualify as innovation. So I don't know if that was helpful to me, because I was sort of like, is it gone or is it redistributed across other buckets in some ways? And just based on what she said there quite confidently, I'm sure that's accurate. And that you'd have to look, I know where you can look in the law, it's 5892, the Welfare and Institutions Code. And it goes through, okay, here are the buckets, and you know, it's a long thing to read, but if you search for that word innovation, you can kind of figure out what's going on there. But that's the best I can give some insight into that right now.
Yeah, and there is still some funding for innovation under behavioral health services and supports right here. So it's just, again, there's not a minimum or a maximum amount that needs to be allocated to that. So unlike previously where there's 5%, or currently, I should say, don't say previously yet, right? Currently, 5% of county funding for MHSA must be allocated to innovative programs, right? So there's definitely a funding stream for PADS. Under the SB 326, there is still allowable expenditures on innovations, but there's not a minimum amount you know, that has to be spent on it. So whether or not counties prioritize innovative programs is up to individual counties, how much funding they get, you know, what their community needs are, et cetera. And I saw in, oh, so Stacy, do you want to jump in? I think you should be able to unmute yourself. Okay, thanks. Whew. All right. So let's see. Okay, so Mark, it looks like you're back in the game. So if you want to go ahead and talk, you should be able to go to do so. Mark Carmetz. Okay. I'm going to put your hand down, Mark. Let's see. Amy Fairweather, you are unmuted on our end.
Hi, can you hear me?
Yes.
Okay, great. I'm sorry if this is a really silly question, but if everything's weighted towards Medi-Cal reimbursement, isn't that like contrary to the whole purpose? Isn't this supposed to be above and beyond, and like in addition to, it's like a separate bucket of money?
Yes, exactly.
Yeah, you got it.
That, yes.
So then if you bill everything Medi-Cal, what do you do with this money?
This is, so this funding is just extra Medi-Cal funding. Extra Medi-Cal funding to pay for very specific types of services and programs.
All righty, well, thank you.
You're welcome. That was an easy question, actually. Thank you for asking. Okay, Stacy, it looks like your hand is up. I don't know if you mean to, but if you are, go ahead. Oh, no. Okay. All right. So it looks like I have gone through the list here, and everyone who had their hand up was able to ask questions. So I'm going to quickly skip ahead here. Sorry if I'm messing with anyone's. So next webinar in the series will be in 2 weeks. We'll focus on the MHSA housing components. We will send out the slide deck. We're going to create a sample letter for you to send to your legislators, which we will also send out to everyone who is registered. So even if folks didn't attend, look for a forthcoming email blast to register for the next webinar, and we will include as attachments or as links in that email blast the link to this webinar recording, the link to the slide deck for this webinar, and the link to the sample letter. Upcoming public meetings and hearings that have to do with these changes. There's a MHSOAC meeting this week on Thursday. So on the agenda is going to be the MHSA modernization proposal update. So you can attend that meeting and provide your feedback. The next legislative hearing is tentatively scheduled for August 22nd. Let's see here. You can make sure that you are on our email distribution list. If you registered for this webinar, you should be, but we can go ahead and look through the attendee list and make sure that you are added. If you want to track SB 326, if you want to track the bill, the amendments, analyses, and the hearing schedule, there is this link. Again, you will get the slide deck, so you don't have to, frantically write this down or take a screenshot if you don't want to. You can also check the Legislative Analyst Office website for more in their series of analyses on the MHSA modernization. They've released 3 that I know of thus far, and they're looking at different aspects of the governor's proposal to modernize the MHSA. So again, if you just go to the lao.ca.gov, you can also just go to that website and type in the search bar MHSA and it'll pop up. Let's see what else. So be there at session 2, attend hearings and public meetings, to provide your feedback. You can also check to see if your county is holding informational meetings or seeking public feedback so that you can, provide your feedback that they can share with the legislature. You can prepare personal public comments, maybe look at your county's 3-year plan or its most recent annual update, identify programs and services that might be impacted or how it might affect you or people you care about, people in your community. Or, if you're a provider, how cuts might potentially impact you. Let's see. And then you can contact your assembly member and or state senator. You can go right here to this website, find your rep.legislature.ca.gov. Again, all of you will get the slide deck, so this information will be in there. And then we will be developing a sample letter. It'll be forthcoming, and we'll send it out to everybody that you can use to tweak, to make additions, changes, whatever, and send it to your representatives. I think that's it. If you want to contact us, our website is calvoices.org. If you have specific questions, you can email Claire, and her email is here on the screen. And you can also call our office. So that is all. Thank you so much, everybody who attended. Thank you, everyone who stayed on here. I appreciate your time. It was really great connecting and chatting with you. And I hope that you have a wonderful rest of your day and rest of your week. And take care. Bye, everyone.
Pride Month.
Bye.
Thank you, Cal Voices.